Good morning, and thank you for being with us. This is Khalil Hachem with US Arab Radio. Happy Tuesday, and thank you for listening. We have a great show for you today. We are going to be talking about in vitro fertilization and what's new and exciting in the world of making babies. With us this morning is Dr. Nicholas Shamma, founding member of IVF Michigan Fertility Center. He is a pioneer in reproductive medicine and infertility. He has performed thousands of IVF cases worldwide and has more than 150 publications in the field. Dr. Shamma, good morning, and thank you for being with us.
Good morning to you, and happy holidays to all our listeners here in the US or anywhere in the world that are listening to us.
We appreciate you taking the time to be with us.
So nice to be with you, especially on this nice day. It's still dark outside, but
yes. Nice. Yes. Dark and rainy, and
there's no rain today, so that's good.
Oh, that's good. We thank the Lord for being here, for being healthy, and that's what's really important. Before we start, we haven't talked for a while. Could you please let us know a little bit just about who you are and what you do, please?
Well, my name is Fake Nicholas Shamma, and I've been a subspecialist in the area of reproductive medicine for the past, since I graduated from Yale back in 1992, so almost 33 years now. And we've been in Michigan and in Ohio for the past 32 years. I haven't moved since I came to Michigan and Northern Ohio. I'm the president and CEO of IVF Michigan and IVF Ohio Fertility Centers, and we have 9 locations in 2 states and 2 major surgical IVF centers, one in Southeast Michigan, which is in our Bloomfield Hills office. And then we have our brand new office, which Surgery Center, IVF Center on the west side of Michigan, which is in Grand Rapids.
Welcome. For those who are not familiar with IVF, what's IVF?
Well, IVF, in a nutshell, started back in 1978 with the birth of a young, now not so young lady by the name of in England, and based on the pioneering work of both Dr. Edwards and Dr. Steptoe, both of whom unfortunately passed away, and Dr. Edwards won the Nobel Prize for medicine for that. IVF basically entails taking eggs in a very simplistic way, taking eggs from the woman, taking sperm, in vitro fertilizing them in the laboratory, making them embryos, and then putting 1 or more embryos into the uterus. And these days we only put 1 into the uterus of the mom who is going to carry the pregnancy. And there's so many different Hisham permutations to this, in terms of where the eggs come from, where the sperm, the nature of the embryos, the genetics of the embryos, and clearly who is going to gestate the pregnancy, meaning carry the pregnancy, and all those permutations do exist these days.
Who's eligible for it?
Anyone. I wish it's more eligible, and maybe that's a good way to start our discussion. Yeah. Let me just give you a background why this is such an important thing, in my opinion. Mm-hmm. Worldwide, believe it or not, and especially in the Western world, if you look at what we call the fertility index, meaning 2 couples or a couple, which is 2 people, should have around 2.1 babies to sustain the adequate growth in the population on this planet. In the US, currently, that number is 1.8 and is expected to continue falling. And if you look at the birth rate, the number of births per population in women between, let's say, 15 to 45, nobody has a baby at 15. But I mean, if you take that reproductively fertile group of women, currently the numbers have decreased substantially to around 55 per 1,000 women in that age group, which is a 22% decline in 15 years. Imagine, 20% decline in 15 years, which equates to somewhere around 2% decline per year. This is Maybe on the short term is good because we'll have less kids to teach in schools and pay less for them. But on the long term is disastrous for economic growth and population, because we won't have enough people that are adults that are paying taxes, and not enough people to help the elderly when they grow older to
Sustain us, yeah.
sustain the population. So unless we do something dramatically to increase access to population growth and entice young people to have more babies, because currently the deaths are more than the babies and are being born, and therefore the population dwindles. Apart from two things that could happen: either we improve the fertility index, meaning we try to tell people it's better to have babies through incentives, through whatever means,
Education, yeah.
or we allow more immigration, and we're talking about here like controlled immigration, not open immigration. So both of those aspects, Khalil, would lead us at the end of the day to maintain that enough population, enough growth and this is to allow us to have a better outcome for the future of ourselves and our kids coming up in the next 50 to 100 years. And we can do this through assisted reproduction. And just to put this in perspective, to some degree, President Trump, during the campaign, actually after a talk that I had with Leila here on the Arab American radio, the same day, actually, he said in Michigan while he was campaigning in Clinton Township that we need more babies. Okay, great. And he proposed that we should have coverage for in vitro fertilization through either the federal government or through insurance companies, which I thought was awesome.
Oh.
Think about it this way. Out of the, what was it, 3.7 million babies born in 2022-23 in the United States, only 92,000 of them were born through in vitro fertilization. And this accounts to around 2.5% of babies that are born. In the country of Denmark, for instance, 10% of babies are born because they see the need for this through in vitro fertilization. And that is because, number one, there is better access and clearly better affordability of the technology, so that it's used by more people, because we need to have more babies born, no matter how we create them, and the technology does exist to help people create more babies. And remember something that, excuse me, two things are happening, Khalil, these days. Number one, the population, the age at which women have the first kid in the United States and in Western Europe and the basically more industrialized countries, is moving towards the end of the around 29 to 32, 33 years of age, whereas it used to be substantially younger before. And as a result of this delay in childbearing affects the fertility rate in women. So they are being less and less fertile. And the same thing applies to men to a significant degree, and it increases the chances of genetic concerns related to reproductive aging in both women especially, and to some degree in men. And therefore, the fertility problem is becoming more of an issue in the population. That is because of this delayed in childbearing issue, and clearly because of environmental concerns related to more pollution, more use of plastics, other chemicals that are present in the environment that affect what we call hormone disrupting chemicals that affect the fertility, chances of a couple having a child.
I see. Now, you mentioned very quickly how it works. Could you just give us more a synopsis? How does in vitro work?
Well, a patient comes to us, let's say, and there are certain indications for IVF that are obvious. Let's say the semen parameters, are substantially diminished, the tubes are damaged in the woman, there is a problem with ovulation that is not basically easily treated with oral medications and so on. And the patient, so they need in vitro fertilization for whatever reason. Then the woman is given drugs to make her produce not just one egg a month, which is the usual way of nature making people pregnant. We produce a bunch of eggs, which we're talking somewhere around the average of around 10 to 11. We produce those eggs, and then we monitor their growth. These are in structures called follicles in the ovaries. And then we do a surgical procedure to extract those eggs. After the eggs are extracted for 5-6 days in the laboratory, our job is to fertilize those eggs, make them fertilized eggs and eventually embryos to reach a 200 cell stage. And then a lot of times these days, almost 80% of the time, we do genetic analysis on those embryos to ensure that they're genetically normal and fit to become babies. And then all of them are at that stage are frozen because the results of the genetic takes usually they take around a week to 10 days to come. And eventually 6 weeks later, we put one embryo back into the uterus to allow the woman to gestate that pregnancy and carry it to term. And I want to underscore one fact, that babies born from IVF are like babies born without IVF. Once the patient is pregnant, she is pregnant, and that's the end of the story. I mean, we monitor carefully for the first 2 to 3 months of pregnancy, and then she goes to the OB, her obstetrician, who eventually delivers the kids and allow that baby to be born and for the parents to be happy.
Sure. Now, what's the rate of success?
It's very interesting that you mentioned this. I know that we're gonna talk about what's new in IVF and,
sure.
and what our accomplishment in 2024 and so on. We just recently published data and paper. We presented it in New York actually just last week, comparing the success rates that we have in vitro fertilization in specific, and that's the first study ever published to date in the world, comparing the success rates after genetically produced embryos, where we only put one embryo into a uterus, in Middle Eastern population in the United States versus non-Middle Eastern population. And we're talking about, we're the largest center that in the US that deals with patients of Arab descent, Middle Eastern descent. And we found literally no difference, even though there's some data from the Middle East that fertility rates in generally is a little bit less over there, believe it or not, than in the US. But we found actually no difference in our hands when I put one genetically normal embryo in an Arab American couple or in a non-Arab American couple. And that was, and we looked at almost 1,500 embryo transfers, and literally the success rates were a little bit, not statistically significant, but a little bit higher. It's around 71% delivery rate in the Arab American population, which is absolutely amazing. I mean,
yes.
One of the highest actually in the country.
Yeah. Now, does the insurance cover this, or this is basically out of their patient's pocket?
Yeah, I remember what President Trump said that
back
in actually, when did he say it? Back in October. He said that he would love to have either the federal government pay for it or part of it, or insurance companies. Currently, I would say maybe 10 to 20% of insurance companies cover in vitro fertilizations, and that is through specific plans that large corporations incorporate into their insurance policies. To give you an idea, for instance, if you're basically working for Apple or Google or Facebook or Meta, whatever it's called, or let's say these large companies, their employers advocate for their employees and entice them by providing those extra riders to allow coverage for in vitro fertilization. And because they want young people, they want smart people, they want educated people, and they basically offer them coverage. And a lot of our patients now use that. And in Southeast Michigan and Northern Ohio, I mean, GM and Ford and so on are getting on the bandwagon and making that happen. And for us in Southeast Michigan, this is like great.
Sure.
even covering, and we haven't talked about third-party reproduction. A lot of them are covering third-party reproduction, including surrogacy. And that we should emphasize this in a little bit if you want, and talk
Sure.
about what it means to have third-party reproduction part of in vitro fertilization, and what's the new things that have been happening in Michigan,
Yeah.
if you wish. So,
Sure. What's a third party? What are we talking about?
so we're talking about, here is the situation. There are certain groups of couples that cannot have babies on their own. And that's categorically. For instance, if a mom is born without a uterus, I mean, they're born without a uterus, or somebody took her uterus out, or she has some severe medical condition, Khalil, that prevents her
Sure.
from ever carrying a pregnancy. Those situations need somebody else to carry for them, correct? And that's called gestational surrogacy.
Surrogacy, yes.
So, and there are some people that don't produce sperm, correct? Period. No matter what we do to them. And even if we're going to get sperm from their testicles, they don't produce sperm. Or certain women that ran out of eggs, either because they're young and ran out of eggs, or they're older, because all patients run out of eggs. All women on the planet, by their mid-40s, they basically have very little eggs left. So in the context of gestational surrogacy, 2024 was, for us in Michigan and Northern Ohio, was actually transformative, to the extent that until this April 1st of 2024, and it was not a joke or an April Fool's Day or anything, the governor in Michigan, after years of us lobbying for this, made Michigan, which was the last state, Khalil, in the, among the 50 states, made paid gestational surrogacy legal by enacting an act, and it was pioneered by one of our representative in Southeast Michigan, Samantha Steckloff, and made gestational surrogacy legal. So there was something called the Family Protection Act, and it's a bunch of bills that basically legalized, after it was illegal until this year, was illegal in the state of Michigan, made the ability of patients to for the whole process to become legal. And it's actually not going to go into effect until March of 2025. So for the past year, what they were doing is putting the regulatory framework that allows judges, allows vital records keepers, lawyers, whatever, what they need to make this process legal in the state of Michigan. Now, we, as part of the IVF Michigan, Ohio fertility centers, and especially at the Gift of Life Surrogacy Agency, which is our sister company, we've been doing this for years out of our base in Ohio, because it was legal in Ohio, actually. And what was interesting is the legal firm that was as part of our agency is the one that took the case to the Supreme Court in Ohio and made it legal at that time. So we've been doing it for years out of Northern Ohio as part of the Gift of Life Surrogacy Agency. But then now that is legal in Michigan, and we will be actually, I think, the first to do any cases in Michigan as it relates to come March of 2025, and we have so many people lined up for that. And the beauty about this process, it gives hope and gives options for people that without could never have a child.
Yeah.
I mean, imagine you have no uterus. There's no way you can have a child. And if your medical condition prevents you from carrying a pregnancy safely to term because of whatever the reason may be, and there are a bunch of reasons, this allows you a safe journey. And the advantage of what we actually put in place in Michigan and recently, and in Ohio for the past several years as part of the Gift of Life Surrogacy Agency, is that we are one of the very few agencies in the US where all our gestational carriers are screened medically, completely medically, before they have a chance to match with intended parents And that's the major advantage that we have over almost everyone. And the reason for this is because yours truly, I mean, I'm the president CEO of both IVF Michigan, Ohio, and of the Gift of Life at the same time. And we have basically now made the same thing happen in Michigan to allow this to serve and help those intended parents that need this process in Michigan so that they can do it safely.
Yeah.
And in my opinion, I think the gift, and that's why we call the agency the Gift of Life Surrogacy Agency, the gift of carrying a baby for somebody else and giving it
to them. Yeah.
Is maybe, Hisham, one of the most beautiful gifts any human can do to any other human. It's not a walk in the park to do this.
Exactly.
Us, with a delivery rate of around 81% last year, I mean, it's just it's just amazing advantage that we can provide for those intended parents that would have had lost hope in achieving a family of their own.
Absolutely. What we're going to do is we're going to take a short break. We'll be right back. Please stay tuned.
Yeah.
With more than 30,000 successful in vitro fertilizations, IVF Michigan is now ranked as one of America's best fertility clinics, according to Newsweek magazine. IVF Michigan fertility centers are the recognized leaders in high-quality fertility care. With locations in Bloomfield Hills and 9 other cities in Michigan and Ohio, IVF has experts in all aspects of the field. A founding member, American board-certified Dr. Nicholas Shamma, is one of the leading reproductive endocrinologists in Michigan and Ohio. He has performed over 20,000 successful IVF cases, and it's helped thousands of couples fulfill their dreams of parenthood. When it's time to get personalized care from Dr. Nicholas Shamma at one of America's best fertility clinics, call IVF Michigan Fertility Centers in Michigan and Ohio toll-free at 855-952-9600. 855-952-9600.
Welcome back, and thank you for being with us. We're discussing in vitro fertilization with Dr. Shamma. Dr. Shamma, we've been talking about IVF. Let us know, please, what is new in IVF this year?
Well, I'm going to maybe break this down into two parts. What's new in IVF with us, and what's new with IVF
in general, yeah.
Let's start with IVF Michigan. As I mentioned initially, is we opened that major center on the west side of the state in Grand Rapids, and it serves all the western side of Michigan, and maybe to some degree northern Indiana and western or eastern Illinois, and therefore it's the state-of-the-art facility, and it has maybe revolutionized infertility care on that part of the state, and there was definite need for it. So that is one thing. The other thing that is amazing, thank God, is that we have been recognized by, you just mentioned in a little bit of an ad, by U.S. News and World Report, that, I mean, we're #1 in Michigan and have been for years now. And that is because not just the efforts of clinicians like myself and our clinical team, whether it's doctors or nurses and so on, but it's also because of the laboratory and the things that we put in place in the laboratory to make it a state-of-the-art facility. And we have maybe, actually, I think we are the highest concentration of PhDs in our laboratories to number of cases that we do. And all of this to maintain a high quality standard in terms of delivering better success rate, because it's not just what we make the patients take and so on to have beautiful embryos that can implant and become babies, but it's also the laboratory setup, and we'll talk a little bit about that in some time. The laboratory setup that I put in place to allow us to deliver this high implantation rate and delivery rates. So that is one thing that we have achieved. We hired more clinicians on the west side of the state to allow also help us in this, and these were, I mean, one wonderful young reproductive endocrinologist subspecialists in our area. So this is one thing that I am very proud of achieving. The other thing is clearly what we mentioned before about gestational surrogacy and the gift of life and so on, and the growth in Michigan that has, and in Northern Ohio, that has been going up by almost 100% a year for the past several years. The third thing is we have put in place more educational programs to advise young women, Hisham, about the need for what we call fertility preservation. And that dovetails on what you and me discussed earlier, meaning women are delaying childbearing. And we have seen almost a 200% increase in the number of young women cryopreserving their eggs and therefore cryopreserving their fertility options as they grow older before they decide, okay, let's sit down and have a family and have kids and so on and so forth. So that is something that I wish becomes even more available for people and more affordable for people. So young women, in case they want to get their PhDs and MDs and JDs and whatever it is they have after their names, and then decide to have kids.
Why is that?
Because, I mean, age matters to women. I mean, if you take somebody in their young 20s, I mean, they have a higher chance of achieving pregnancy than somebody in their 30s and mid 30s and late 30s. And that's the reason for that, is because the eggs become abnormal as one ages, meaning genetically abnormal, and therefore the likelihood of them being fertilized successfully and becoming babies without genetic concerns becomes less, and miscarriages become more. So if you want to preserve your fertility, you might as well have a very good insurance policy with eggs around. And I can share with everyone that I have both my daughters have eggs frozen, so I don't really care when they want to have their kids, because they will have kids if they ever want to utilize those eggs. And you don't have to use them. That's the beauty about this. You get married or you want to have children and achieve children naturally, I mean, you can potentially destroy them. You don't need them anymore. But if you need them, they're right there waiting for you to become babies eventually. Clearly not all of them, but some of them will become babies. So that is actually a big thing, in my opinion. The other thing that
what's the cost for that, doctor?
Currently, it's around $10,000.
Okay.
To do so. And again, a lot of big corporations cover that. The insurance called fertility preservations. There's another aspect to this, and we're doing more of it. And again, I wish there was more awareness for that, which is people that have been diagnosed with cancer or conditions that require chemotherapy or transplant or stem cell therapy, and they're gonna lose all their eggs anyway, or sperm for that matter. So we are advising those people in a very short period of time to have enough eggs frozen, so that again, if they go through the chemo and they wipe up all their eggs or sperm, then they have sperm, eggs, cryopreserved, frozen for later on use, once, God willing, the overcome the concerns related to cancer or whatever it is that they were taking the chemo for. So that is again a major achievement with us. The other one is we are actually doing more and more cases, and that actually pertains to our Arab American community, more and more cases related to genetic disorders in the population. And those are divided into two groups. Clearly, I mentioned to you that now we are able to select a genetically normal embryo as best we can and put it back in a woman to gestate the pregnancy. And that is to make sure there's no Downs, no Turners, no Klinefelters, no other conditions that could affect the quality of life potentially of babies born. But we also now deal with situations relating to two aspects. One, if both parents carry a genetic recessive disorders or genetic dominant disorder that is passed along to the children, or what we call X-linked disorders, and screen the embryos for that specific, I'm going to give you an example in a minute, for those specific disorders and put them in. And I would say currently we do around 10% of our cases because of those concerns. And because of higher rates of consanguinity in our Arab American population compared to Western civilizations or people in the United States generally, there is even more need for this because, I'll give you an example. There's 20 to 50% of marriages in the Middle East are consanguineous. I mean, you marry your cousin or second cousin or something. That increases the risk of all that stuff. Currently in the United States, 6 to 8% of people have genetic concerns together. They're Caucasian, but they might carry a gene, let's say, for thalassemia. And I use that because it's very common in the Middle East. So where we screen the embryos for the thalassemia and put only one embryo that does not have thalassemia major, that would affect clearly the quality of life of that individual. So we are doing more and more of this to the extent that it's around 10%. The other thing that we're doing is something very interesting related to the risk of cancer, because think about it this way, 10 to 15% of all cancers are genetically originated, meaning people pass that gene to their kids, and therefore they are at higher risk of cancer, their kids will be at higher risk of cancer. And it's a little bit ethically charged, but at the end of the day, if we can avoid, if we have options of using this embryo or that embryo, one embryo doesn't have that gene that predisposes the kid for cancer at a younger age, we will use that embryo instead of the other embryo.
Exactly.
So that is, again, part of that why 10% of our current patient population will have, in a sense, genetic evaluation and testing of the embryos before we put that embryo back to minimize the risk of cancers in the next generation.
What's thalassemia?
Thalassemia is a blood disorder whereby the red cells, I mean, it's associated with severe anemia and very severe anemia and thalassemia majors, and it's very common in the Middle East. Very, very common. And people don't realize that those genetic disorders, somewhere around 1 in 20 to 1 in 30 will carry that gene.
Yeah.
And imagine if you're consanguineous, the risk of you having that same gene with your partner is a much higher, consanguine meaning, and you're related to that person you're marrying. And you don't have to be related. Let's say if you come from Lebanon or Syria or anywhere in the Middle East, I mean, just living in the same community or the same city puts you at risk, because go back 2-3 generations, everybody is related to everybody else.
Exactly.
So that is something that is more prevalent, and we advise all our patients when they come to see us for fertility issues, for them to be tested. And currently we test literally around 611 genes to make sure that once we put the embryo in, we are putting, as best we can humanly wise, an embryo that is free of genetic concerns that affects the next generation, that affect those babies once they're born.
Yeah. Before we talk about what's new with IVF in general or nationwide, let's take a short break.
Sure.
With more than 30,000 successful in vitro fertilizations, IVF Michigan is now ranked as one of America's best fertility clinics, according to Newsweek magazine. IVF Michigan fertility centers are the recognized leaders in high-quality fertility care. With locations in Bloomfield Hills and 9 other cities in Michigan and Ohio, IVF has experts in all aspects of the field. A founding member, American board-certified Dr. Nicholas Shamma, is one of the leading reproductive endocrinologists in Michigan and Ohio. He has performed over 20,000 successful IVF cases, and it's helped thousands of couples fulfill their dreams of parenthood. When it's time to get personalized care from Dr. Nicholas Shamma at one of America's best fertility clinics, call IVF Michigan Fertility Centers in Michigan and Ohio toll-free at 855-952-9600. 855-952-9600.
Welcome back, and thank you for being with us. We're discussing infertility and fertility treatment with Dr. Nicholas Shamma. Dr. Shamma, when we're talking, before we talk about in general changes in fertility in IVF, when we're talking about testing, are we talking about both men and women?
Yeah, I mean, there are 2 types of testing, as I maybe I didn't make it clear. When the patient comes to us, They are both tested for numerous things, clearly anatomically to make sure and physiologically that they're okay, but they're tested genetically, meaning through a blood test for whatever genes that they have or don't have that could affect the next generation. So that testing is done for the patients themselves. When we actually test the embryos, we test the embryos by taking few cells out of each embryo, around 3 to 5 cells, and do the genetic testing on those 3 to 5 embryos for two aspects, either to make sure that the embryo does not have an extra piece of chromosome or a piece of chromosome, or does not lack a piece of chromosome or a whole chromosome. And we also test them for a specific genetic disorder if we know in advance that the parents have the two abnormal genes for that specific disorder. So the testing is done both on the intended parents on the front end, and it's done on the embryos clearly based on the testing on the intended parents. And I wish to some degree, think about it this way, 2% of all babies born on the planet will have a genetic disease. And 10% of cancers are to some degree preventable, to 15% are preventable based on genetic concerns. In theory, and I'm not advocating we do that, but in theory, we can prevent all of them.
Yes, yeah.
But that implies everybody before they get to conceive a child, the intended parents are tested for this type of stuff. And I can tell you, us working almost 7 days a week, 5 to 7 days a week, I should say, there's not enough of us to do that.
Yeah.
So we cannot provide this service for the whole population. So, but at least the ones we see, we offer them, Khalil, that type of testing to try as best we can to provide the best, I'm going to use the best within quotations, the most desirable, God willing, babies that they wish for. And now there is some, again, ethical considerations to this, because who am I to decide that this baby, no matter what it has or doesn't have, ought to be born? And I always leave it up to the parents to decide. I mean, I never introduce my own feeling and prejudices and all of that.
What's the cost for the test?
To do the genetic testing itself is a couple of $100, but to do the genetic testing on the embryos is somewhere around $5,000. So,
but it's a good start to do the blood test, and I mean, we have a chance to really have a society by design. I mean, with all due respect to what people think about other things, it's like, my God, the most important thing to me are my children. I just want to make sure that we're compatible.
So I'm going to just go back a little bit and step back and tell you that in medicine and in basically epidemiology, the purpose of those two disciplines is not just to promote health, but also to prevent disease. So if we have the option of preventing disease, that ought to be, Khalil, that one of our major hallmarks of our discipline in general in helping patients.
Yeah. It's just amazing.
Yeah, well, I mean,
we don't make those decisions. Yeah.
And what is interesting in our field, and maybe I just sort of discussed it briefly without people, understanding it completely, is that the whole field is literally only around 45 years old.
Yeah.
So this whole thing did not exist before 1978. Did not.
Yeah.
Therefore, if you think of it, all of those changes for people like me who basically I started, I was a doctor back in 1985. So, I mean, think about it. That's quite a bit of years, but in those 40 years or so, all of this happened.
Yeah.
And
remarkable.
And it's remarkable to be able to do this. And I think that is why it was easier for us, Khalil, to open centers and do this. And thank God for I mean, I'm going to say thank God for everything, of course, but thank God for the privilege that I had in allowing me to start when this thing just started. And,
Sure.
and allowing me to help as many people as I
Yeah,
can.
yeah. I mean, look at where we are now. I mean, we have personalized treatment plans, we have a pre-implantation genetic testing, assisted hatching, and I also would like you to talk about what is the role of AI in this, if there is a role.
Okay, so now that AI thing is a big thing because there are certain disciplines in medicine that I think will no longer exist come 50 years from now. I mean, if you're a dermatologist, let's say, AI can tell you anything you want without, I mean, you'll send a picture to AI and it'll diagnose your disease, give you treatment, and that's it. You don't need
Yeah.
maybe the biopsy that you'll need someone. Or if you're a pathologist or a radiologist, because I mean, AI can look at any X-ray better than any doctor and tell you the
Sure.
result.
Sure.
The same thing as a pathologist to look at slides. I mean, of course, AI can do it better. So I have a brother who's a dermatologist. Hopefully he'll retire before then. But anyway, so in our field, what's new is that AI is being incorporated into what we call assisted reproduction, meaning there are currently actually 3 platforms. There is what we call A-Life, there is what's the name of the other one, Life Whisper, and so on. And the other one's called Future Fertility. All of those we're incorporating them in the laboratory to give us, and in clinical practice, to give us a better assessment of what are the best protocols to stimulate ovaries and what are the nuances related to patients. Because no matter how good we are, AI is always better than us. And in the laboratory, it adds another dimension in the ability of certain programs, especially now that we have what we call time-lapsed videography of the embryos, where we actually look at the embryos in real time all the time and see them dividing, to tell us which are the better embryos, apart from certain morphological milestone that we have always used, to tell us which embryo has a better chance of implanting than another embryo. And therefore, again, if we have options, we'll choose the one that has a better chance of implanting, and we do that all the time, but it adds another layer of achievement. And that's one of the things that we have incorporated back in 2024 to take us to the next level of improving the success rates for any journey taken by somebody going through in vitro fertilization. So that's where I am.
Yeah.
So that's a good way to start about what is new and what is now being developed in our fields.
Yeah.
The other one that sort of dovetails on AI is basically robotics. So a lot of the processes that we have, Hisham, in the laboratory were done and continue to be done by humans. And actually every single step, imagine, is actually checked by 2 humans, not just 1 human, by 2 humans. Every single step in the laboratory to make sure that there are no issues that come up with related to mixing of stuff. And therefore, robotics will allow basically more, I would say, industrialization of the process, meaning a seamless entry and lack of human touching of the embryos, and therefore lack of things that can happen to those embryos. So, and that's robotics. And there are, again, many platforms that we are introducing in the laboratory that allow this to automate the process and to some degree decrease the rely on humans, because humans are humans and we always have issues. And that is a big thing in our field. Other thing that is happening that happened in 2024 and has been happening for the past few years is what we call clinic consolidations. And we have been, until recently, I should say, is one of the very few large clinics that offer all this stuff, assisted reproduction, that have been freestanding. And I think consolidation in our field is a good thing because it broadens the know-how, allows us who have built major practices to become even more visible on the national level and introduce policies and standard operating procedures to make 2 things happen. Number one, to improve the the clinical take-home baby rate, because that's the ultimate goal, and at the same time to put safe and effective policies and procedures to allow a better outcome for,
Mm-hmm.
for our patients.
Mm-hmm.
And I think it's a good thing, and I hope it's going to be a good thing, because we're all joining the bandwagon at the end of the day to make this possible. And there's a lot of economic reasons for it, but there's also practical reasons for patients in offering a better experience, and what we call patient-centric experience, in allowing a better outcome eventually for those patients.
Yeah.
And it's interesting because this also again dovetails on what we talked about before, because we're not offering this part of just IVF Michigan, IVF Hawaii fertility centers, but also part of the gift of life. And that's where it's all in the experience, Hisham. It's all in the experience of people realizing that their doctors care about them. Their doctors and clinicians care about the outcome that they have, and put everything in place to make this journey as successful as humanly possible. And that's part of the major changes that are happening in 2024. A lot of other things have to do with better access. We need IVF to have better access. And as I was going to say Dr. Trump, President Trump said that we need more babies. There's no question that we need more babies. And the way to have more babies is to entice insurance companies and entice corporations to offer insurance coverage, and the federal government for that matter, offer better coverage for our patients so that they have more access to in vitro fertilization and the technologies that we have put in place. Now, on the positive side also, we have put a lot of things in the laboratory to allow successful changes for the future. And I'm going to mention some of them. We have had in the past used morphology, basically the way embryos look, in terms of deciding if they're good or if they're bad. We add another layer to that by looking at the genetics of the embryos, like I shared with you, what part of pre-implantation genetic testing, meaning we take a few cells of the embryo, we test them, we make sure that the embryo is genetically as good as it is, and then we put it back. But now we're adding several layers to that. Number one, we are now looking at the embryos, believe it or not, in 3D. 3D actually, and 4D, meaning that it is in real time we look at them. And there is recent work from us, from Spain and so on, that showed that if we do this, we actually improve the implantation rate for any particular embryo by choosing, again, the better embryo to put back if we have all embryos looking genetically equal and whatnot.
Yeah.
The second thing that we're doing in the laboratory recently is looking at what we call the metabolism of the embryo, meaning we know that the embryo has to have a particular pH, a particular temperature, particular what we call osmolality in the fluid around it, and so on, and whatever amino acids that it needs, sugars in the environment around it to sustain it for that growth. But in a sense, we have yet not looked at particular needs of specific embryos, meaning we are recently looking at the culture media around the embryo, where we actually keep it in the laboratory for the 5 to 6 days, and analyzing the fluid around the embryo and deciding on those metabolic changes that are happening to decide, again, based on our evaluation of that fluid, again, which embryo is better suited to becoming a baby later on. And that's amazing to some degree, because all of those paradigms, whether it's the shape of the embryo, whether it's the genetics of the embryo, whether it's the 3D, 4D imaging of the embryo, whether it's the metabolism of the embryo, are all being incorporated to maybe choose the best embryos suited for to become a child later on in life. And I mean, just for as a matter of example, we have actually found that in people with recurrent pregnancy losses, with another dimension related to infertility, that again, if we look at the metabolism of the embryos and we add certain what we call cytokines, these are immunomodulatory agents that the body usually produces, to the culture media, we actually can improve the implantation by almost 40%. Those people and minimize miscarriages. And that's a recent study that was done in Spain, in Catalonia, in Spain. So the point that I'm saying, all of those things in 2024 hopefully bode well for the future of the technology that we are offering, and eventually the experience of those intended parents in realizing their dreams of having families. And we're all for that. I mean, I truly believe, Hisham, that our field is maybe the most rewarding field in medicine, because every single day we touch people for 30 years to go, not just we make something go away or something, or we fix a broken. We actually affect generations. And we do it in a very loving way. And therefore, by offering a better experience, meaning both medically, know-how wise, and emotionally, as far as emotional support, we are able to get our patients from A to Z.
Yeah, exactly.
In an almost seamless, loving, supportive journey.
Absolutely. We're going to take our last break, and then we'll come back and talk about education. Please stay tuned.
With more than 30,000 successful in vitro fertilizations, IVF Michigan is now ranked as one of America's best fertility clinics, according to Newsweek magazine. IVF Michigan fertility centers are the recognized leaders in high-quality fertility care. With locations in Bloomfield Hills and 9 other cities in Michigan and Ohio, IVF has experts in all aspects of the field. A founding member, American board-certified Dr. Nicholas Shamma, is one of the leading reproductive endocrinologists in Michigan and Ohio. He has performed over 20,000 successful IVF cases, and it's helped thousands of couples fulfill their dreams of parenthood. When it's time to get personalized care from Dr. Nicholas Shamma at one of America's best fertility clinics, call IVF Michigan Fertility Centers in Michigan and Ohio toll-free at 855-952-9600. 855-952-9600.
Welcome back, and thank you for being with us. We're discussing infertility and treatment with Dr. Nicholas Shamma. Dr. Shamma, it sounds like there has been incredible improvements and advances in the treatment. Don't you think more education is needed so people know what their choices are and what precautions they need to take?
Absolutely. I mean, what you raise is a very important question, and I think it has several dimensions to it. Yours truly and the other people in our group, our clinicians and so on, we are offering, discussions like this early in the morning, to be able to advise the public, to advise our listeners, our viewers, to what is new in our field and what they should and should not do. And we try to tell them, for instance, don't wait too long to have kids, because it affects your chances of success. Try to avoid so many different things in terms of education. Try to avoid being a little overweight. Try to avoid drugs. Try to avoid substances that could affect your fertility. Smoking, alcohol, all of it. Even marijuana, that is unfortunately ubiquitous now. Everybody uses it in population. You go down the street and it smells marijuana. It's horrible. So all of this stuff, Hisham, we're trying to advise in terms of us providing, talks, discussions like we're having in the morning, to advise our patients of what to do, what not to do. The other part of it is we always advise them, like we just discussed, the young women, that if you're trying to delay your childbearing, you need to have some framework. Within the marriage, you should freeze embryos if you're not willing to have a kid next day. Or if you're not married, try to, in a sense, provide some option for the future of freezing your eggs in case you decide to marry at 35 and have kids at 39, or 37 or 38. So all of those things are part of education. Even educating doctors, what I mentioned briefly is how little we see of patients that have been diagnosed with potentially curable cancers, and they're given chemotherapy before discussing with the young people at the time with leukemias and lymphomas and other types of tumors, that maybe we can cryopreserve your eggs for later on use, or sperm for later on use. And it's not the job of the patients, knowing that is being overwhelmed by anxiety and stress and emotions because they've been diagnosed recently with cancer, but it's the job of their doctors to tell them. And Hisham, they don't tell them. They give them the chemo because that's the problem on hand right now, but they don't tell them of the option that if, and God willing, when their chemo is being given and then they get out of this hump, the option does exist later on for them to have kids.
Sure.
So that is all part of education. I mean, so the aspect of education has to do with us providing the information like we're doing today.
Sure.
It's people to take charge themselves of things they can do in their lives to prevent infertility.
Yeah. I would recommend that there'll be like a 1 page of notes that will be given to the mosques, the churches, and everybody saying when you're performing marriage ceremony, give them that sheet so they can study it. I strongly recommend that.
When I go to pray, I mean, I try to become as small as humanly possible.
Sure.
With that being said, I wish it's all available, not just in all public forums. People need to realize that. And the third aspect to this, as I mentioned, Khalil, is that I think doctors that take care of people that might need our services, not to delay or their ability for us to see them and send them our way. And the other thing is, in situations where they're going to wipe out all their options for the future, provide a venue that allows those young people to preserve their fertility for the future.
Absolutely. Dr. Shamma, it's been a pleasure, as always, talking to you about this exciting topic. I want to really thank you for taking the time. Wish you and your family and your staff and everybody is involved in this great, great work. Happy holidays, a wonderful, happy new year, and a wonderful time.
I want to take this time also to say thank you for Layla, for you, for the ability to do this.
Absolutely.
And I want to wish not just here in the United States, where I live, been living for many, many years, but for all the people in the Middle East. Maybe what is happening with the new administration in the US and what's happening in Lebanon and Syria recently and so on is, and hopefully God willing in Gaza, is for things to change for the better, to offer the people that where we originated for
Sure.
part of the peace and serenity and hopefully economic growth that they deserve.
Yeah. Thank you. I really appreciate it. Thanks a lot. Happy holidays.
You too. Bye. Bye.
You know.